far left, we have Senator Dennis Mendiola. To his right, Senator Paul Manglonia. To my far right, Senator Carl King Neighbors. And assisting the committee, we have Legal Counsel Antoinette Villagomez, Fiscal Analyst David Mapon, our Legislative Assistants Devin Macronis and Jolene Dagobah, and Sergeant at Arms Benjamin Terlahi and IT Del Camacho. We have Senator Karina and Senator Selena Babauta, who will be joining us momentarily. And with 4 members currently present, that constitutes a quorum to proceed with today's committee meeting. Now, before we proceed, members, can I get an adoption for today's agenda? All right, the motion was made and seconded. All in favor, say aye. All opposed, say nay. Motion carries. We now move on to the next item, which is public comments. If there's anyone from the public that wishes to make comments, please limit your comments to 5 minutes and state your name and the entity you may be representing.
Good morning, colleagues, staff and management of CHCC, and most importantly, the viewing members of the general public. My name is Marissa Flores. I'm a 23rd House of Representative representing Precinct 3, in addition to the entire Commonwealth. I understand that today is the budget hearing for the Commonwealth Healthcare Corporation. And I am not here, as we all know. They've pleaded with the House several months ago. I have been in communications with the Secretary over some concerns that I had during their presentation in the House. Today, I'm not here to discuss what has already been shared with the House of Representatives, but I will be directed to where the Secretary has directed me to look for further information should I have any more questions, and that is the 2020 citizen-centric report. I'm only going to concentrate on the strategic goals in which she has, and the management and the board of directors, I assume, have approved, discussed, and are probably aiming towards its success. One of the biggest things and the issues and concerns I have as a taxpayer, as well as a member of the society, is that we seem to tend to always send our people outside of the CNMI for basic health care services. That is an injustice. We can no longer afford to send our people out for basic health care. To have our people receive health care overseas only to die is an injustice. Our people, whether we can agree and disagree, don't want to go to CHCC because they're afraid to die. We do not have the basic equipment, staff to provide basic healthcare services. So now I'll direct everybody here to her first, or the corporation's first strategic goal, providing quality and affordable care to the community. What does that mean? Have we provided quality and affordable health care to our people, including Rhoda Antonian? And I ask this committee to ask those tough questions. Have we? And if the staff and management believe that they have done so, I would like to hear it. I'd like to hear their goals and objectives, and if they've been met, and what are those timelines look like. Number 2, maintaining a comprehensive data management system to track health patterns and trends in the CNMI. How is this done? I know several of my family members who receive health care at other service providers only to find out that their folders that contain their information cannot be shared and is not being shared with CHCC, who is the main service provider for the Commonwealth, the only government-owned healthcare provider. So the only time my relatives get their information logged into a system is when they're in the emergency healthcare unit seeking services from CHCC, because their main service provider, their main healthcare provider is either CAGMAN, Community or CAGMAN Health Center, Dr. Alaloo, his center, his healthcare provider. There's so many. But how is it that if the strategic goal number 2 is to maintain comprehensive data management system, how is it possible that people who do not seek to go to CHCC for basic healthcare needs and choose, because they have a right to choose who will be their healthcare provider, and that data is not being shared? So when they go to CHCC on an emergency, are they getting quality healthcare service? I ask myself. And I think this committee should ask too. Increasing financial efficiency to make investments into improvements to facilities, equipments, and services. How do they do that? And what is their plan to do that? Because I still see our people panhandling on the side of the road for basic coverage, for supports. And I'm not going to discuss that because that's not why I'm here. That's your job. And I respect your committee to ask those tough questions. Recruiting and retaining staff from both US and abroad. I'd like to know what the revolving door looks like, because I'm pretty sure she lost 3 people in the past 3 months, maybe a quarter or 6 months. And I know this because, again, I have family members that receive services from an outside service provider. And the one professional that my family member needed to see just quit. So is that meeting the strategic goal? What does that revolving door look like? How many people, how many professionals have we lost in the past 3 years? That's aim and hired to provide quality care to our community. Improving the corporation through professional development and staff training. I have nothing to say about that. I think they've done an exceptional job. But we can all agree that our purpose here is to do right by our people, figure out ways to work together to improve the healthcare services system in the CNMI. And I'm almost done. Chair. On page 4 of her centric report, she talks about teledentistry for Rhoda and Tinian healthcare services or centers. And on the last paragraph, it states, although plans are in place, the CHCC has not been able to secure the funds needed for the initial equipment and software investments. So let's go back to, again, her strategic plan. And you can find that in the Office of Planning and Development website. Last August, which was 2 years ago, 3 years ago, because that's the last time we had a report. Last August, the CHCC reached out to the local Tinian and Rhoda delegations for funding assistance of roughly $230,000 for its initial investment. to establish the long-awaited services for both islands. FY 2021 budget appropriates just $86,659. Now, mind you, I'm sure everyone in this House, both Senate and House of Representatives, have done their due diligence to providing as much financial assistance to this corporation. However, she and the management, Ms. Muñoz, Madam Secretary, and her management have a fiduciary responsibility, including the Board of Trustees, to figure out ways to find investments, opportunity, to ensure sustainability of this corporation. I ask you, colleagues, to ask the tough questions, not for me, not for you, but for the people who deserve quality healthcare and affordable healthcare in the CNMI. Thank you. I yield.
Thank you, Representative Flores. The floor is still open. All right. If there's none, we move on to the next next item on the agenda. Introduction. Good morning to everyone present here today, to those viewing online. Today we start off the budget hearings with the CHCC and to determine the corporation's needs as well as how we can assist. And while we have not received any information from the House as to how much they are going to appropriate, we've started our budget hearings to just get the process started so we can have a smooth passage of next fiscal year's budget. And so from our fiscal analysis report, CHCC is requesting for 100,743,000. This includes 808 positions and requesting for 60 new positions. But that's just for the hospital operations itself. They're requesting for 9,663,000 to manage the health network program. And so based on their budget proposal and the reports that we've submitted from them, CHCC is expected to is projecting around 99,233,000 in revenues. And so we're here to see how we can assist in providing the additional 1.5 million just for the healthcare corporation alone, but then also understand the expenditure breakdown of the health network program in which they are seeking the additional close to 10 million. And so at this time, we have the CEO for CHCC present here today. And so CEO Munya, if you can please join us in the chamber, as well as any members of your team that will be part of the presentation and that can assist the members in answering the questions that we have. And so at this time, CEO, if you can make your way over, as well as your team. Yes. And at this time, we move on to the testimony by CEO Munya. You have the floor.
Good morning. Good morning, Honorable Chairperson Manglonia, and honorable members of this committee. Thank you for the Thank you for the opportunity to testify on the fiscal year 2024 budget related to the health and well-being of CNMI residents. Joining me are Chair Polly Mosca, CFO Perlita Santos, CSO Caitlin Nices Mocano, and other key leaders of the CHCC. The FY24 budget approved by the CHCC board was a compilation of health system needs that will bring better health to the CNMI. It builds on the organization's success over the 13 years since it became a semi-autonomous agency with the intent to align with what you and the governor want for the health of the CNMI residents. This budget provides a strong and resilient health system that will serve our people, an available workforce, affordable treatments and services, and access to healthcare needs for all. Before I turn over the PowerPoint presentation, focusing on health finance to Ms. Nices Mocano and Ms. Santos, I want to emphasize two top priorities as you consider the FY 2024 budget for the People's Hospital and Health System. First is the workforce. During the COVID-19 response, healthcare workers at the CHCC were working 2.5 times longer to meet the demands of the community at a wage that was 3.5 times lower than their counterparts of travel nurses. CNMI's only hospital was not immune to the crisis of staff burnout and staff shortages. It was therefore necessary to make an unprecedented investment in our workforce as recruitment and retention continue to concern us to this day. Adequate patient care staffing is required to comply with the CMS conditions of participation, which hospitals like CHCC must ensure to get paid by Medicare and Medicaid. As with other entities in the CNMI, the workforce shortage is further exacerbated by the touchback provision. The second is financing for health in the CNMI. As a reminder, the CHCC continuously provides services to the uninsured and deals with several financial gaps as a safety net healthcare provider. You have the power to help us with these gaps by providing the CHCC with funding for services to the uninsured, financing for the CNMI government's responsibility to match the cost of providing care for Medicaid patients, and funding for the medical referral program. We are aggressively working with patient assistance programs to provide access to critical medications for our patients treated at the hospital and beyond. A hospital foundation is in development and will have a board's governance soon. However, it is not enough. We need the CNMI government's funding support. Receiving cost reimbursement only from Medicare and Medicaid is never adequate for any healthcare provider, and it is certainly inadequate for the largest provider in the CNMI. And with cutbacks and funding shortfalls of the Medicaid program, the CHCC is experiencing non-payment and underpayment for the cost of services provided to Medicaid patients in FY 2023. That is a $12 million shortfall before the end of FY 2023. And it is why the CHCC cannot take the additional financial burden of the cost of the Health Network program, the government's medical referral program. There are many more priorities that keep us up at night, from behavioral and mental health issues that are plaguing the community to lead poisoning and the lack of policies that encourage healthy behaviors and lifestyles. Those priorities are considered in the FY 2024 budget. In closing, we are grateful for the opportunity to present to you today. We understand the financial situation of the CNMI government. We're asking for help to ensure that every resident in the CNMI has equitable access to healthcare and an environment that helps them achieve that. We appreciate your time and support. Jesus Mas Angeliso.
Thank you, Mr. President and members of the Senate. As the CEO said, my name is Caitlin. You can call me Kate. I'm the Chief Strategy Officer at the CHCC. And I'm going to walk you through some of the successes that we've seen in the first 10 years of the CHCC. This is similar to our House budget presentation, if you watch that. We have made some additions in terms of our financial resources and our expenditures within the last 5 years, and also some updated data on our cost cuts, our ability to cut costs for the medical referral program and maximize value for that program. Next slide, please. So we're going to go over a little bit of the history of DPH and CHCC, a little bit about our revenues, our costs, and then what we're asking for in terms of support. It's not $100 million, but what we're asking for in terms of support for medical referral and the Medicaid local share. Next slide, please. So maybe you've seen the slide before. It's our origin, and I think it's important. Anyone's origin story is important to understand where we came from. We came out of a really tough time in the CNMI. I happen to be here, and the CNMI government simply did not have the money to fund the Department of Public Health. And so it spun off a public and autonomous corporation in the hopes that it would be able to generate sufficient revenue to operate independently. And through that, with that lack of funding in the first few years, there was some serious CMS problems. Staff were leaving; they weren't getting paid. We didn't have equipment, supplies, et cetera. I'm sure you all remember those times. But since that time, we've made a pretty significant turnaround. And I wanted to also acknowledge that in our birth, there was the acknowledgement from the legislature that the CHCC would still need assistance to subsidize indigent care and medical referral until we have universal health coverage in the CNMI, which is a goal that we are passionate about at the CHCC as well. So I just wanted to flag that. Next slide, please. So to see our growth in the first 10 years, we have significantly increased our employees from 585 to 874 in 2021. Our total expenditures have also roughly doubled. And you'll see where those expenditures go, at least over the last 5 years. And we've also about quadrupled our revenue. So in terms of our goals and what we're supposed to be doing for the CNMI, so creating value, we feel that we are accomplishing those goals. Next slide, please. A little more detail on what that means. So the operating deficit, and this is taking out or not looking at government appropriations, the operating deficit of the DPH before the CHCC was established was around $30 million every year that needed financial support from the CNMI government. So that's CNMI local funds were going into that. Since that time, we've made strides, and still we struggle with deficit, largely due to the lack of the local share that we get for Medicaid. So between 1999 and 2011, on average, the amount that was appropriated and transferred to the Department of Public Health from the CNMI government was about $40 million every year. The CHCC has never received even anywhere close to that amount of money, but we're still maximizing value and maximizing services. And next slide, please. So if we compare our operating deficit, and again, this is without CNMI public funds into consideration, and that is just to show the CHCC's business operation on its own without subsidy. In comparison to the local share not received, you can see that in most years, the Medicaid local share not received outweighs our deficit. So if we were to be made whole through Medicaid, we would not have a deficit. I think that's, and I'm going to hand it over to the CFO. Sorry, I should have had the CFO do those slides. I'm going to hand it over to the CFO for the next slides. Or actually, do you want to talk about the CPE? Sorry. Okay, next slide, please. You want to talk about finances?
Here's a breakdown of our revenue and how we have grown our hospital services revenue throughout the years. This is through investment in equipment, through investment in new services like oncology, and onboarding specialists like cardiologists, podiatrists, ENT. So it may seem like CHCC is not enough because we still have significant medical referral, but we are able to onboard what we can. Hiring specialists from off island to live in a remote island of Saipan is difficult, but we have successfully done in some areas where it is critical. We have opened our oncology center in 2019. We have onboarded, as I said, oncologists, ENT, and these specialists do quarterly travels to Tinian and Rota to provide services there as well, or maybe monthly travels to Tinian and Rota, depending on what is scheduled need of the patients there. So we continue to, it is evident in the revenue that we continue to grow our hospital services revenue as other funding sources decreases. Next slide, please. And so as for the cost, it is as a hospital, the primary cost to operate is personnel. We are always challenged to reduce costs. But when you are providing services and you are trying to attract and retain healthcare professionals that are getting paid 3 times more in the mainland or where they practice, it is very hard to cut costs when a significant portion of our expenditure is personal cost. And next to personal cost is medical and pharmaceutical supplies. As services increase and as we serve more people, those are directly related costs. They correlate directly to the increase in service. We cannot provide service without buying the pharmaceuticals and medical supplies. So it is really, there are ways to cut costs, but it would be really hard to cut costs without cutting services. That is why we're trying to manage our margin and our mission. We have to sacrifice margin to serve the mission of the hospital. Next slide, please. Okay.
Thanks, CFO, for that. So looking at our services capacity and how we've grown. So how have we turned dollars into actual services serving patients? Since 2017, CHCC dentists have been traveling to Tinian and Rhoda. And I know there was public comment about teledentistry. We have secured funding. That was a report from 2020. We have secured funding for teledentistry, and that is currently underway to provide full-time services on Tinian and Rhoda for dental care. And since 2017, our family care clinic volumes have increased by 340%. So we're seeing more than 3 times the number of patients that we were in 2017. We're seeing 226% more patients at the children's clinic and 154% more patients at the women's clinic. So you can see that we've significantly increased even just in the last 6 years, 5 years, 6 years. And every day we see roughly 218 patients at Saipan's medical clinics every day. Next slide, please. And our hemodialysis services have increased. This is not something that we look for, but we are expanding capacity to meet the demand. So I think the only day that's closed now of the dialysis center is Sundays. And other than that, they're open quite late to serve the demand. And that is driven by largely diabetes, hypertension, those kinds of diseases in the community. Since opening the oncology center in 2020, off-island referrals for oncology have reduced by more than 70%. So that is a huge investment for the CHCC. Chemotherapy drugs have significantly increased. If you notice, the medical supplies budget increased over the last few years. That is largely due to chemotherapy pharmaceuticals, which are extremely expensive. So that was a big investment, but it meant that a lot more patients could stay on island for cancer care. Next slide. And in our radiology department, since 2017, average monthly procedures have doubled. And since our first year of operation at the outpatient pharmacy, the average monthly fills increased 6-fold. So we fill more than 300 prescriptions every single day at our outpatient pharmacy. Next slide. And the same story with our laboratory tests. You can see even just from 2022 to 2023, our laboratory capacity has expanded significantly from about 12,000 tests in a month to almost 18,000 tests. And the CHCC's labs on Saipan and Rhoda, now newly, last year Rhoda, is now a CLIA certified laboratory, which is a huge success. This means that our laboratories can conduct moderate to high complexity tests. That's a huge value to the community. And thus far in 2023, about 3 out of 4 lab tests run at our labs are moderate to high complexity. And in terms of just some basic, oh, next slide, please. Just some basic measures of the quality of care at the hospital. The average length of stay at CHCC is about 4 days, and the US national rate in 2019, which is the most recent average, is 5.4 days. So that shows that we are making sure that patients are not staying longer than they need to. And then as far as readmissions would show if we are discharging patients before they are ready or before they should go home, or maybe they're not set up with the right information or the right medications or the right support at home. But our readmission rate is about half of the national average. So that means we do not, when our patients leave the hospital, they stay out of the hospital by and large. So in 2022, the CHCC's readmission rate was 8.4%. So the readmission is calculated as a patient coming back to the hospital for largely the same condition within 30 days. And the national average was 15%. So that's about half. Next slide, please. In terms of our revenue, Medicaid is our most important payer. This was 60% of our revenues come from Medicaid. From private payers, that's 19.7%, about 20%. And the bulk of that comes from Aetna. So about 70% of those private payers' revenue comes from Aetna. Self-pay is only 1%, and then Medicare makes up about 20% as well. Next slide, please. And since presumptive eligibility for Medicaid ended in May, we are anticipating seeing the same rate of uncompensated care that we did before the pandemic, which is roughly $15 to $20 million a year. So Medicaid got a lot more people covered, and it was great in terms of healthcare services, getting people covered and getting them to come in for care. However, we're looking at going right back to those pre-pandemic levels without the supports needed through some kind of a universal health coverage or just better insurance support generally in the community. Next slide. And I'm just going to go over the key components of our Medicaid financing because it's important for legislators to know. And I know I talk about this a lot, and I'm sorry if I'm being super repetitive, but the FMAP is what the federal share is. So right now we're at 83%. The local government funds is the match. So 17% of that is expected to be funded locally to match that. Our federal cap is the Section 1108 allotment. So that's the maximum the federal government will pay into the CNMI's Medicaid program. And if you're following the news, that Medicaid has actually already reached that cap for this fiscal year. So that's where the funding shortfall comes from. And anything in excess of the cap would need to come from the local government funds. And then the last component in terms of CHCC is the certified public expenditure. And that is a way for the CHCC's hospital to receive the federal share by putting up our own costs as the local share, right? Which we've been reimbursed for once in 2013. But the CPE is based on cost. So it's not based on bills. There's no margin. It's based on our actual costs. So those are the four important components of CNMI Medicaid financing. And you can see that, so thanks to significant congressional action over the last 5 years, our Medicaid funding ceiling has expanded significantly. So generally, it's about $6 or $7 million a year is our federal cap. Over these years, it increased to, and now it's about $64 million. And in FY 2023, the FAP is 83%. However, in FY 2023, only $380,000 was appropriated for Medicaid reimbursements. Now, if you can do the math quick, that doesn't add up, right? So largely that local share is put up by the CHCC's own costs. And that's what we'll talk about a little bit in the next slide. So the local share of Medicaid outstanding since 2012 adds up to about $91 million. And that's, again, CHCC's costs. And you can see the rate varies, and largely that's because of the change in the federal map or the FMAP. So around our, Typhoon U2, the FMAP increased to 100% for a short time. And so we were actually reimbursed more fully. And then there's a lower local share. Next slide, please. And in terms of the CNMI medical referral program history, we went back to 1968. The documents there, it's always been a funding problem. There's always been a funding problem with funding off-island referral. Even in the trust territory government, there's been movement by this legislature, not this legislature, but legislatures in the past to implement cost sharing, trying to figure out how to fund this program. It's always been tricky. And in 2022, the HNP law was established, which formally transferred the medical referral program to the CHCC. Next slide, please. So we had done a report for ourselves, anticipating that the medical referral program would be our responsibility. We looked at, okay, what does this mean for us? What does this mean for our finances? And one alarming thing that we found was that actually the average annual deficit for FY 17 and 19 was about $11.4 million. So the dark blue is what was appropriated for medical referral, and the red, the entire amount is what was actually spent. So we, being an autonomous agency, not being able to have funds transfers, et cetera, we knew this was a huge risk for us to take on this program because of this deficit. So what we've done is reduce costs, next slide please, by 50%. So since 2019, which is the most reliable, pre-COVID estimate of what was being spent on medical referral, in 2022, our costs were half of that. And that is without changing any eligibility or benefits. We're simply following the regulations that were already there. And that's partially due to our investments in, like I said before, oncology and ENT and ortho. So you can see the reduced off-island referrals between 2018 and 2022. And again, we jumped over COVID because that was it was a weird year. There was not a lot of referrals going on. But in 2018, there were about 375 referrals for oncology, and in 2022, there were 88, just to give you an example of that. And that's all for me. Thank you.
Thank you, Kate. Can you provide the committee with a copy of your slides? Thank you. Earlier you mentioned that your request is not 100 million, but can you just, I'm going to break it down and just let me know where the discrepancy is coming from. Your request for personnel costs is around 77 million. All others is at 43 million. Or actually, I'm sorry. Your personnel cost is at 77 million, but they zeroed out your additional requests of 274 vacant position, which comes down to 61 million in personnel costs. Your all other expenses is at 43 million less CapEx, which comes down to 39 million. So that's a total of 100 million in operational costs. Is that correct?
Yes, sir.
Yes,
May
Ms.
I?
Bailey.
Our budget request is segmented into our total request to be our ceiling, which is at 77 million per personnel. And if we are not fulfilling our revenue, then we would not fill vacant position, which will bring it down to 61 million. So in essence, we are requesting for a budget cap of 121 million. It's not a funding request, but a budget ceiling for CHC at 121 million. And to calculate the subsidy that we are requesting, which was at 1.5 million, we had to take out the vacant position and the capital expenditure, for which we are hoping to find funding for the capital expenditure through other funding mechanism. So our request for CHCC subsidy amounts to 1.5 million. But note that on our revenue projection, we have included the 7 million local match as projected revenue.
Thank you. Sorry, before I begin, I'd like to recognize Senator Selena Babalta and Vice Chair Senator Karina Magofnia. And so with that, what is the need for the 274 additional positions? That's, amounting to 16 million that unfortunately it will not be covered by your projected revenues.
A significant portion of that would be medical professional to fulfill certain ratios and to reduce overtime.
And so if you're okay, well, it looks like in 2023 your initial request was 71 million, which jumped up to 77 million. And so with that, these are for all 4 additional FDs, correct? We're looking at a 5 million increase from the current fiscal year.
The increase of headcount from prior year's budget to this year's budget request is actually 59 positions. Of that, that's the increase in personnel headcount. It's presented on page 3 of our budget summary. 1, 2, 3, 4. Yep. And then a part of that 59 is actually the absorption of medical referral staff. Yes, and some required clinical staff as we increase services.
Okay. Now, and of those 274 vacant positions in which you're trying to fill or had proposed, how much of this would actually reduce the cost on the H&P?
So there's some that are our medical staff and of course the hospital staff, but these are positions that we actually requested from years before. For example, in HR or maintenance, there's a lot of need for maintenance staff. The building, it keeps expanding. A lot of services have been increased, and the maintenance staff has really not increased at all. So we're looking at those areas where staff are actually working overtime right now, and so we're trying to fill them. We never filled them because of the obviously not meeting the Medicaid match from the previous year, and especially now with the shortfall of $12 million from Medicaid, we can't be able to fill those positions. So we're bringing those positions back up to the FY 2024 to see how we can try to get those positions filled and reduce our overall overtime costs. And of course, there's clinical staff all the time that we have to have openings. We do have locums. Those are individuals, physicians that are coming in on a quarterly or a short-term basis. And as we're recruiting, we have to have the positions open. So we need to make sure that there's a bucket where the employee can go in, right? So we need to make sure that those positions again are available so that we can continue with the recruitment. Again, it's difficult to recruit when positions are filled. So there is no FTE for it. So we are trying to make sure that these FTEs are available for the recruitment. In regards to trying to reduce the referrals, yes, we are including some specialty care, but there's it's a little bit more complex because again, it requires a team to bring. For example, in cardiology, we have a cardiologist, but he's not able to perform some procedures, especially the most complex procedures. So there's a lot of things that we need to fill, and those are so the new positions are the what we've added really is, as CFO mentioned, is 59, but the 274 is the positions that were vacant since FY 2023.
Yeah, thank you. And earlier you mentioned your challenges with the touchback provision. What what if what does that look like for CHCC?
So we have personnel in the lab as well as radiology and in nursing that have to do the touchback. There's a couple that are leaving in September, and there's some in December, and again in FY20. I mean in May 2024 and December 2024, all the way up to December 2025. I can provide this copy to you.
Do you have a number of FTEs?
We have, sorry, we have, yes. So the total number of employees for 2023 is 12. And in 2024, 22. And 25 for the 2025.
Have you worked or are you working closely with NMC? And if so, how many of their graduating students are entering into that nursing field?
As soon as so even for NMC graduates, there's always a push for them to try to get their NCLEX. So we do have the graduate nursing program that exists, which is, without the NCLEX, they have 1 year to work for our CHCC. We actually provide bonus for them to try to, to take on the graduate nurse program, to become a graduate nurse versus, just not, I guess not working. So we try to encourage them to work, at least for the graduate nurse program. And then we also provide assistance for studying. We provide administrative leave and even pay for their tests if they request it as well. But yeah, we're working closely with that. We're trying as much as we can to try to have them work, especially to fill the gaps of the touchback. So we did hire, I believe, maybe just less than a handful that we've hired. Some of them are pursuing their NCLEX. So as they're getting, in fact, one of the staff that works for us right now is a graduate nurse, actually recently passed their NCLEX. So they're gonna, obviously they're gonna get promoted to a registered nurse.
Do you know what's the average of graduating nursing students for each, I don't know, semester
for
or school year?
Each school year is about 15, I believe, this past
Okay.
past cohort.
Okay.
Yeah.
Thank you. So now I guess we have two separate entities that we're looking at: CHCC subsidy and the health network program. So in trying to address your CHCC subsidy request, you're short of about 1.5 million. Is there, just looking at your operational or your all other expenses, is there any way you can cut 1.5 out of there? I mean, I see your total request for, let's say, furnitures and fixtures at 253,000. Your travel expenses at 555,000.
The travel expenses are for inter-island medical referral, just for clarification.
So it's not included in the health network
it's not
program
for
request?
staff. It's not for training.
No, I mean it's not included in the separate health network program.
No.
So why is there a separate program?
Because the public the Corporation Act actually incorporates the inter-island medical referral. So that is our responsibility by law. The health network program is still government responsibility.
Okay. But all other expenses, I mean, cleaning services, 948,000. Is there anywhere where you can cut from all these other different expenditures to meet the 1.5
Well,
while we address the H&P?
the H&P and the subsidy, yeah, sure. I mean, we've done it before. Every year we know that there's, we are making the ask because we know that in order for us to fulfill those requirements, then we are going to basically request that shortfall, the $1.5 million. However, at the end of the day, when we're looking at our operations, we also look at what will CMS say, for example, for Medicare. If it does not, if we're still within the line of compliance with Medicare, then we can make those cuts. But if they're not, then we can't.
What did you say? If you're still in compliance with Medicare?
If a cut prevents us from complying with Medicare requirements, then we cannot make those cuts. But there's some that we could, and we will make those determination as they're received when, and a lot of times when, for example, there's been requests for maintenance, some of the maintenance actually got approved by the SIPEN delegation for funding, and it was in our budget. It's just that we were not able to pursue it because of the lack of revenues or the lack of cash that we were able to have. But so we just make those decisions as we go along.
Okay. The 3.8 million for utilities, does that include what payment arrangements you have with them currently?
The projection for FY24 is at anticipating commercial rate.
Okay. And the professional services at 5.5 million, what does that consist of?
It includes locums doctors that are not on our personnel but are on professional contracts. It also includes provision for traveling nurses for the touchback, and it also includes provision for other professional services for our ancillary units for maintenance of certain licenses. And yeah.
Okay. Now moving over to the health network program. Your request at 9.6 million. It looks like you are taking out LA and San Diego for next fiscal year. Or is that just included in the hotel costs, accommodations?
They're still there, but there's no office expenditure for LA and San Diego.
Okay.
So,
Now, I know in our earlier meetings, you mentioned possibly shifting into maybe Philippines or other Asian countries. Is that proposed, and is that included in your plans for next fiscal year still?
yeah, we were not able to amend this budget request to reflect any change in where we send patients because that's dependent on the CNMI Medicaid program adopting a state plan amendment to allow sending of Medicaid patients to non-US facilities.
And so if that state Medicaid plan is amended and has approved Philippines, what does the operational cost look like? How would that look like for the HMP?
The costs will, there will be an impact from HMP, but there will also be an impact with Medicaid. It will definitely reduce the cost of air transportation. It will reduce the cost of care, from the fact that it's obviously cheaper healthcare billings than for example, California. So you would see that impact in both Medicaid and HNP. For us, of course, again, not only the airline, but you see the reduction in the airline. So right now we're paying, for example, $2,000 to $3,000 for Los Angeles or Hawaii. That will be reduced for some of the patients that are not covered by Medicaid. So patients that are eligible that may not be covered by Medicaid will be able to to fly to the foreign country without having to pay them in thousands.
Okay, but you don't have a fiscal impact right now as to what that will look like.
No, because as CFO mentioned, we are not sure what the Medicaid action will be.
Okay. At this time, I'll yield to any of the members that have any questions. I recognize Senator Paul Manglona.
Just a follow-up. Can you elaborate more about that non-US facility for Medicaid, Medicare again? And what's the, how feasible is that? Or what are the challenges? Or what do we need to do? And how long do we anticipate if we were to pursue that route? And I guess the bottom line is your projection, is that significant amount? I know you list all the benefits, but can you elaborate on that further? Because Guam just recently, right, was approved. So knowing that, what's the challenge? What are the challenges?
Sorry. So just close this. So the significant impact again is really the airline cost. For medical purposes, that's really under the Medicaid. Now, one of the reasons why we can't pursue that, and we only have agreements with these facilities, we do have agreements with Medical City, and we're hoping to have some agreements with Korea as well. The agreements is really just about, picking up the patient from the airport, bringing them to the facility, especially if they're hospital to hospital transfer, and helping us find the cheapest hotel rate, for example, if they're looking for, if they need lodging. In regards to medical care, though, those are something that we don't want to be burdened on the referral program. If we're sending patients right now to Philippines without proper utilization review, they're going to have a challenge in the cost. We saw that a lot of the expenditure, if you go back to 2018 expenditure of medical referral, they were paying for the medical costs. They were paying for the medical costs in Busan and in Philippines, and that's a lot of the costs for coming from the medical referral. So this is one of the reasons why we don't pursue foreign countries, because Medicaid itself does not allow for foreign hospitals to be reimbursed. We have suggested to Medicaid. However, it does require the approval of Medicaid, the government itself, CMS, to approve such a plan. It's really just an action, I believe, from this the CNMI Medicaid agency to pursue it. But
I think that's my main question is if we pursue the Medicaid avenue so that we can qualify our patients. That's my question, and that's where I'm asking, what is your financial analysis? Does it really benefit us?
yes,
Because then we can actually have our patients undergo procedures, right? Surgery at much
Right.
cheaper cost. So
and it's
have you
closer-
done that, or what do we need to do? That's with Medicaid office, not CHCC?
Not CHCC.
Working with Medicaid? And
No, it's Medicaid agency making the request for the recommendation for a state plan amendment. They have to pursue it.
But doesn't CHCC benefit from that if that were to be
Well,
allowed?
the HNP program will benefit because, like, again, it'll be cheaper, it'll be closer, it'll be even emergency medevac, for example, much cheaper than. I
Well, and
believe-
for our patients that do not have insurance also, right? I mean, if we have patients that doesn't have insurance, they can actually then,
yes,
I guess, benefit from the cheaper rate that we have arranged, right?
right. But again, one of our concerns is that once we open the door, there's going to be a flood of claims that are going to come our way, which if Medicaid cannot pay, then medical referral has to pay. The HNP has to pay, and we don't want to pursue that because there is obviously not enough funding coming to the program itself. But yeah, it is a matter of Medicaid state plan changing. We can facilitate the transfer of a patient. We've done it already. We've been doing it. We actually send a patient depending on their insurance. We're looking at the insurance, trying to make sure they are authorized. We are facilitating that already for the uninsured and the insured that accept foreign hospitals. But for Medicaid itself, they cannot be transferred that way.
Let me ask you, if we're going to go that route, how long would it take us? How long did Guam take to qualify?
Well, CNMI actually has a bigger or better waiver than Guam. So if CNMI wants to do it, they can do it.
They can do it.
They can do it.
Sorry, Senator Paul. Just to kind of piggyback off of that, so y- I'm sure you've had this discussion with CMS, right?
I have had discussions with CMS Region 9 and with CMS,
And
CMA here.
And what is their response into looking at amending the state plan?
CMS response is whatever the governor wants.
Is the governor aware that
Yes.
this is a proposal that
That's
has been
actually
thrown out?
he signed off on it already. It's I believe it's still pending on the CMA in the CMA office.
So it's the CMA office that has to send it off to
Correct.
Region 9.
I don't know if they did. I really don't.
But the governor has approved this.
I believe he did.
Okay,
Yeah.
Thank
He
you.
did tell me that. He did.
Senator Paul, you still have the floor.
Well, I have others. I'm going to allow the members to ask their questions. But before I do that, just going back to the medical referral program, and I know that we're trying to address the 9 million requests for next year. But let me just step back and ask. Presently, since the infusion of some money to the medical referral, where are we today between now and, let's say, the budget passage, as far as subsistence allowance? Is that restored now for?
Yes, that's been restored. Yeah, that's been restored.
So patients presently off island that has been sent months ago, they're getting your checks?
Yes, they're getting their pay card.
Because I hear some patients continue to call us about subsistence allowance.
We've been processing it, but unfortunately, some of these patients left without a pay card. So that's one of the reasons why they're
So they should be
They should be yes.
expecting.
right.
And of course, those are the ones that were sent, and for the new ones under the new enforcement policies, depending on whether they're qualified, they can expect the subsistence allowance.
Correct.
Okay. Can you elaborate more on the certified public expenditure so we can kind of get a handle on that? Because I know in your request you're asking for $7 million, so the members can have a better understanding and appreciation for your request. Can you just explain that again a little bit more in detail?
Okay, I'll try. Sure. So, in fact, actually, you were probably the speaker at the time when we were talking about this back in 2011 about certified public expenditure. That is a methodology that the hospital agreed to accept as a means of getting at least some payment from Medicaid. It was designed, in fact, it was created because of the fact of the government did not have the matching funds, and it was faster way of drawing down the funds, and it's only based on cost, and I want to emphasize that there it is not based on charges. We have provided we've billed for charges. We bill Medicare for our fees. They make a payment at the end of the year. We're required to submit a Medicare cost report, and they reimburse us based on our cost if our cost is higher than what has been billed as charges. So that's always been the tradition, using the Medicare cost report. So it is it is a shortfall for the CNMI for CHCC, because we're not billing Medicaid what other providers are billing for their services. Even though it's in our fees could, for example, be $3,000 per night for a common, for the room, for room and board. But Medicaid and Medicare will not pay us based on the 3,000 a night. They will, in fact, will pay us based on our cost to provide services. And the people that are incorporated into that cost are the administrative staff, HR, um, maintenance, accounting, and nurses and ancillary services, not doctors. They're not part of our Medicare cost report. For doctors, we're billing those for services, and we are actually required in those services. Medicaid has to pay us the matching. So we have several bills that we sent to Medicaid that still are unpaid because they don't have the match for those medical doctors. So we're paying for the doctors, but we're not getting reimbursed for them by Medicaid. The only thing that we're getting reimbursed from the Medicaid CPE is really the ancillary costs. Those are the costs of lab, of respiratory therapy. Those are items, and they're only paying for Medicaid patients. They're not paying for the entire CNMI services that we're providing to everyone. They're not paying for the uninsured. They're only paying for their patients. So even if the fact that we're asking for a match of the cost is really minimal, if we are going to turn back to Medicaid and say, we don't want to be paid under CPE anymore, we want to be paid just like any other provider, then the CNMI government has to match those at a higher rate. So we're in some ways doing a favor to the CNMI government, to Medicaid agency, by allowing us to only get reimbursed by cost versus being paid by any other like any other provider using charges. And so this is why it's a continuous request every year, help us, because we're helping Medicaid by drawing down their funds, because if they don't draw down their funds, they're actually gonna lose them. If we're talking about $64 million, it's not gonna go to the CNMI government. We're helping with the drawing down of the funds. We're helping with the cost of Medicaid. We're helping with the government not being able to at least pay those charges versus paying the cost. So this is why it's important for this body and the legislative body to think about Medicaid CPE. Should not be a burden only at CHCC, considering that that's all we're getting. And there's your gaps that needs to be identified. I hope that answers your question.
So maybe what about a compromise where, because I know you're saying now or in the past, and we see in the chart there $91 million over the years, right? What about somewhere where we meet in the middle? Is that, I mean, not that I'm not saying we can afford it now. I mean, but I'm just saying something like that, because I guess some members or we look at it as, so you get Medicare and you use CPE to get it. So in a way, it doesn't cost you because you have to spend those CPE anyway, right?
No.
So we look at it sometimes like that. So it helps you that Medicaid can allow for that CPE to get your 60 million. And so I'm just saying, is
wanna
there
answer?
any way where if we can get a compromise somewhere in the middle there?
So we will not get the 60 million if we do not spend 80 million. Let's say the percentage now is 20% local, 80%. Let's simplify the ratio because it's gonna be harder if I do the 83. So if we are on 80-20, we are not gonna get 60 million if we do not spend, because it's cost reimbursement. So the CMS every year gets our total cost and tells us, and then remove an allowed cost in there. Like They audit our costs. For example, this is 100 million. These are total costs for the year spent. It cannot be not spent. It's a 100 million cost, right? They take away the providers, the professional services. So it's shrunk down to 80 million. Then they will take away non-CPE costs, Tinian, Rota, Inter-Area Medical Referral, CGC, Public Health, BEH. Then that will further shrink, right, to 85 million. So that's our total cost, for example. And then what they will do is get the total of Medicaid population we serve. For example, we say about 70% of our population served are Medicaid. So we will get the total CPE will be 70% of our allowed cost. So when you're saying when we get 64, that should be enough. It would not be enough because the 64 is just 83% of the total cost. The cost has been incurred for us to get that 64. Right? So like for every dollar spent, allowed cost, for every dollar allowed cost, we get 83 cents. So we get 83 cents. So we're short 17 cents for every dollar spent on a Medicaid patient. So that's to simplify things. Is like when we take care of a patient, to simplify, we spend $100 to take care of that Medicaid patient. We will only get $83. If we are doing fee for service, that clinic visit would have been $300 charge. Right? So we are saving the government by not doing fee for service, right? Because a $300 charge would be required mandatory upfront local match before they could draw down the 83%. The advantage of a CPE is they would be allowed to draw down the 83% without fronting the local match. Because in essence, as a government agency, we should be subsidized by the government for that discrepancy, for that difference.
Thank you.
It's a little complicated, but yeah, it is, I mean, certified public expenditure. We opted it for it because at the time back in 2011, the government did not have any matching funds. And it was the only way for the hospital to get funding for it.
Thank you. Yeah, I was a bit confused there because you went from dollars and cents to $100 and $83 and so on. But thank you for clarifying. I recognize Vice Chair.
Thank you, Chairman, and thank you, CHCC and team. So let's stay with the example that you gave with $100 for a Medicaid patient, and out of that $100, you would only get reimbursed the $83. Wouldn't your normal revenues that you generate cover for that?
Then, did you want to answer it? The normal revenues. Okay, so if you're only getting 83% of Medicaid and you're getting 70% of the population, that's 83%.
And I understand
Yeah.
that, but I mean, we can't simply just rely on Medicaid to pay 100% of the cost that the hospital has incurred to provide the service, right? So also the hospital is also in the business of generating revenues
Correct.
to pay for its operations.
Right. So again, this budget was in the mind of the fact that we are using the methodology of Medicaid, CPE.
Got it. So
We have a choice. We actually do have a choice. We can actually tell Medicaid right now that we don't want to be paid under CPE, that we want to be paid under charges, but we're going to sit around and wait for the funding because they will not be able to draw down the funds because the match has to be paid. As I mentioned earlier, the professional services for doctors, we're not getting paid for that. So there's a lot of revenue. You're right. We're in the business of making money. How can we do that when certain things are not getting paid in a timely manner? We're only getting, again, reimbursed with the 70% population of Medicaid, of our patients being on Medicaid. We can't even bill for those services. We're just not getting paid the adequate funding, and that's really a big gap.
Sure. So let's circle back then to the revenue, right? Is your revenue projection based on your actual costs and not necessarily what you would have charged, what you should be charging? Because in order to operate a business, you have to incorporate all the costs that
Yes.
you incur to function, right?
Th-
But
this
if you're
is a cost. Right. This is a cost.
so that so the revenue projection is based on
It
actual
is. It is
costs.
based on costs. It is based on costs, and but with also with the revenue projection. But we did include the revenue projection of Aetna because we bill Aetna exactly what our fees are. Calvo's insurance, everybody else pays the same what we charge, but except for Medicaid.
And I understand that you're saying that you're actually doing the government a favor by not charging what you guys should be charging, right? And instead are just reporting what your actual cost is. But I also see that as an issue for CHCC, right? Because if you're not capturing, what you could be generating in revenues, you're also affecting the way you could allocate those costs across your operations to be more efficient, to be more effective, and so I understand what you're saying about saving the government some money, and I understand too that part of the reason is because the payment, right? The lag of payment. And what I guess, I mean, I don't think the government is ever going to take responsibility and accountability to pay what is due to CHCC if we continue, not we, sorry. I feel like, part of the issue is that we are, CHCC is enabling, right? Because instead of holding them accountable and saying, hey, you guys need to pay up what is due to CHCC so that we can continue to function and operate, we're also, CHCC is also kind of playing into that, like, okay, yeah, but they're not doing this. So I'm just saying the concept is enabling. We are in,
You have to understand too that there is a cap. So there's $64 million. Our projections are about more than that, right? So there's a cap, and if right now, for example, as everybody probably heard, we were adjusted $9 million, but that's based on cost again, and it's from cost that's already expended, not future costs.
Mhm.
So even for that what's that, when you're talking about the cap funding, if we are going to start charging, one of the reasons why we were requesting the government to pay us that $9 million was because we won't be able to see any adjustment until 2 years later, because that's how Medicare cost report works. They have to settle, right? So the reason why I'm saying it's not enabling is because, again, the government still has to pay the match. There is a match requirement of 17%. So if the government doesn't pay that in CPE, and we're not going to get paid, we're further not going to get paid for charges. Imagine the charges. And in the meantime, because the government, as we see, that the government still does not pay even the match for CHCC. They would pay for private clinics, but they would not pay for CHCC. And yet and so here we are, we're not so much enabling, but we need to also, we have an operation to have, and if we can't get funding from Medicaid because they can't match, then that's the reason why CPE is the most ideal, because at this point, if the government doesn't have the money, at least we get the 83% better
Okay.
than
Okay,
zero.
so I stand corrected. I now understand, and I misunderstood that part. Now, when you say that the government is also not meeting its obligations to pay, its portion, right? Like, has CHC ever considered like suing the government for not meeting its obligation to pay the match? Like, I don't understand why, if it's an obligation and it's already
Okay.
Never mind. Scrap that question. Okay. Okay.
Yeah.
So can we
Yeah.
look at the worksheet that we were provided, that was I'm assuming it was provided by your office, the Health Network program. And on that worksheet, we have a projection for fiscal year 2024, but we don't have 2023 to compare it to. So is there a reason why the 2023 figures were not listed on that worksheet?
We can share it. I have the numbers in front of me right now if you have
that would be
questions.
great. Yes, just so that it can give us an idea of what we are looking in 2023 versus 2024, where the increases and decreases are. And because my next question would be like, what were the basis or the justifications for these figures that were provided? So, for instance, like payroll is 0.
Mm.
Like,
That, yeah.
That is the law requiring us to absorb personal cost. So all
Got it.
personal cost of H&P is under the CHCC main budget.
okay. And then I see the Guam office is higher than the Hawaii office by 64K. Uh,
Because of the turnaround, a lot of them are outpatient services, and
okay.
they're getting subsistence if they're not an inpatient.
Under the Guam office. But there's a line item there for subsistence. So is the subsistence also included in the
No,
line?
they're processing. They're seeing more patients than Hawaii and everywhere else.
Okay. And under professional services for $840,000, can you elaborate a little bit more on what those professional services are?
There are certain providers in Guam and Hawaii that do not accept Medicaid, and the medical referral has to front the professional services for that. That would be like and then we also included in our budget the fee for the Island Surgical Center to come into Saipan to perform the procedure here rather than sending patients to Guam.
So this lump sum of 840K would cover all the different locations.
Yes.
Okay. And then, so yeah, could you please share with us the 2023 so that we can see the variances between the two
And
fiscal years?
you will see a large variance between the request and the actual. It's much lower. The actual is much lower because the request was based on prior years, and like we said, we've already cut costs significantly. So you'll see that we spent less than we projected, but those projections were based on past years' expenditures.
Okay. So I'm done with that worksheet. Can we go back to, so the 274 vacant positions that were adjusted, are any of those positions critical positions? They are, but we're adjusting them to remove them from the budget request is what I'm understanding. Oh, subsidy requests. Okay. And then the 16 new positions, like what does that amount to?
I didn't do a sum if of those new position. It's just like a tally of FTE, but I could do that.
Are you able
And
to tell us what kind of what positions are those?
A significant portion of that is the absorption of the H&P program. Let me go to 26 personnel from the health network program was absorbed. We're looking at one additional FTE for Rota, one additional FTE for Tinian, 12 for mental health. There are some CGC funding that are sunsetting, and we're projecting to transfer that to local. So that is essentially the 60.
Would you happen to have the cost breakdown for those?
Yes, I'll do
Okay.
the cost breakdown for those.
Okay. And then the one position that was zeroed out, what was that for?
It's inpatient pharmacy.
And how much?
Oh,
is
it's let me go to the detail.
Okay. Mm. Okay. And then if we look at the revenue projection for, you had given a breakdown of 2021, 2022, and so forth. We see that the FY22 column is still at projected revenues. Do you have your actuals for 2022?
Because when we do our budget projection, we base it on the average projections for the year. So, but we do have the actual already. We can provide that to you.
So is this the actual significantly different from what your projected
The actual
revenues
is
are?
significantly higher because of adjustments because of PE, which is not anymore present in 2024. That's why we cannot use the actual to base our projection off, because our actual has an outlier, which is the presumptive eligibility. So we
Couldn't
have
you-
to base our
Can you
projection.
just remove those from
Yeah.
your actuals and then have
Okay.
a good basis to
Yeah.
project? So I see that in your 2022 projections against 2023, there was an increase, but in 2024, we see a decrease. So under Medicare and Medicaid, they both decreased in revenues. Any reason why for the decrease?
Active eligibility.
Oh, okay. And then you have a line item for Medicaid prior year adjustments in 2021 and 2022, 5 million and 8 million. Can you elaborate what those are?
That would be for, as we explained earlier, we did not include that the PE plays a significant portion in the adjustment. These are costs incurred in 21 and 22 for PE that we are projecting to recover in FY24.
Okay. And then under private insurance, you have all others. So can you just share with us what some of those all others are?
All the other private payers that are not Aetna, Cabo, Netcare, Moylan's, TRICARE.
Okay. Okay. Okay, that's all I have for now. But I'm just curious: are there any employees off island that are employed under CHCC?
Yes, for the HMP program.
Okay. Okay. Thank you. Are you for now? Thank you.
Thank you, Vice. Any other member? Recognized.
On the medical referral numbers, will you agree that for ground transportation, it's probably like 3% of the total medical referral expenses, right? For ground transportation, 200,000. That's out of. In other words, it's not that significant, right? And I guess my question is, would this be something that because after we have applied the new medical referral policies, a lot of people do not qualify, right, presently, but yet they still have to go to Guam, maybe get treatment, or Hawaii, and a lot of these patients that do not drive. They cannot rent a car, or they have an escort who doesn't drive, right? And they cannot rent. So is that something that you can recommend to the legislature, a policy change for, even if you're not under referral, if you ask for assistance, but you're a resident here, there can be a different structure there, so that at least if they're in Guam, they can get picked up at the hotel to be brought to their appointment, not to go shopping or sightseeing, but to actually go from their hotel to the hospital. Or could that policy be amended somewhat? Because I find that there are patients that are actually going on their own, but they need ground transportation assistance. And looking at the numbers, it's not that significant compared to airfare, accommodation, and subsistence, right?
So the ground transportation is only for, I believe, for LA and San Diego. Those are
What
not.
about in Guam?
So Guam is basically it's part of the operations of the the offices. For example, Guam and Hawaii, they already have drivers, so they're already incorporated into that. That ground
Oh,
trans-
but the patients now, if you're not under referral and if you're in Guam, they
We
cannot call
assist.
up to be dropped to the hospital, I think.
Every patient who wants assistance, whether or not they're qualified for any other assistance, if they are in Guam, for example, and they need assistance for ground transportation, and our staff are available, they just need to make sure that they have to go through the system of getting an MTA, a medical treatment authorization. So
Oh, and where do they get that before they
they
leave?
have to go through the HNP program.
Before they leave, right?
Yes.
Oh, okay. So they can actually qualify then.
They could, if they're, again, if they all else just they don't qualify and they can be fitted on the schedule, they can be assisted.
Okay. Well, that's good to know. Thank you. Because of the new enforcement and application of the new medical referral policies, what percentage would you say the cost dropped significantly? What percentage are we looking at?
We have showed you earlier the 50% cut since drop since previous years, and that we don't anticipate that to change.
No,
So
I
it's about
thought that was
50%.
that 50% was since 2018 or something like that.
No,
But
since we took over.
since you took over,
Yes.
50%. Okay, thank you, Mr. Chairman.
Thank you, Senator Paul. Just several follow-ups. The regulations for inner island versus the off island, are they the same? Do you follow the same regs for both programs?
No, they're different.
So what are so if the off island is based on eligibility, how does are all inner island patients provided the inner island referral?
We're basically, it's about equitable access. We feel that Rhode and Tinian should have equitable access as people from this site, from Saipan.
Okay.
So whatever services we have, we don't look at income. I mean, at the end of the day, it's access.
Okay. So that kind of brings me to my next point, and that is that the municipalities of Rhode and Tinian have always assisted, I would say assisted CHCC in the sense that we do provide some housing to our patients. So say, if there's an issue with some of the housing units or the rooms, is that something that CHCC can assist with in trying to repair or address?
Yeah, we do that whenever the liaison housing is like aircon is down and there's people with medical condition there. We put them short term on the hotels that are funded by the CHCC, Inter Island Medical Referral, for what the municipality covers are long term patients, the those that are doing dialysis and pregnant. And the one that we take care are those that are transient, like they're here for a visit and they go back. Right? Those are the one we put on hotels. And whenever there are issues with the housing that is provided by the municipality, Tinian and Rota, they contact our travel coordinator, and we do accommodate them on a short-term basis on the hotels until the issue with water, power, or aircon is resolved, and they are released back to the housing.
Right. Well, I guess my question is kind of like, can CHCC assist in whether it be looking for grants or some kind of funding to help repair additional units so that could also save on CHCC side? Like, I know, for example, with at least on the Rhoda side at the Navy Hill Guest House, right? We've always had this issue of trying to get it in operation. I mean, that's like, I think, close to 10 units that could save CHCC 10 rooms, the cost of 10 rooms. So is that something that CHCC can assist in trying to repair?
I guess we need to meet with them because we are not even aware of any of those issues.
Okay. Yeah. And I just bring that up because, like I said, those rooms could save CHCC 10 the cost of 10 rooms at a hotel, right? Another thing that I want you to also kind of look at in terms of inter-island air travel is to reduce costs in the sense where like some of these patients come here for a day procedure or a consultation for an hour or something like that, but yet they end up staying a week long because there are no flights back. And so there's some kind of mechanism to determine whether you can buy that round trip ticket, whether it's cheaper to amend to change the ticket versus waiting for the next opening, next available seat for that patient to return. So is that something that can be looked at? Because not only is it costing, again, CHCC every day they stay at the hotel, but it's a burden on the patient having to sit around and wait for the next flight out.
We do that already. We are assessing the situation, and we get the request. Like, for example, if they want to charter the flight, then we look at it, and especially if the cost, like you said, if it's going to cost this individual to stay longer, and it's what is the cost of charter, we look at that and say, okay, well, it's cheaper to charter than having this patient stay at the hotel. Of course, we do that already.
Okay, thank you. And you mentioned earlier that you were awarded a grant for teledentistry on Rhode Antinian, and you're hoping to have full-time services there. Is that correct?
I'm not sure. I think they've pieced together several different sources of funding. I don't think it was just one grant. We've tried. There's issues with the way that the USDA defines telehealth, that we're not eligible. This kind of project is not eligible for a lot of the telehealth funding that's been more available through COVID, which has been frustrating. But I believe they've pieced together different sources of funding to make it happen. But the plan has been there. Yeah.
And so that hasn't been finalized yet in terms of having a full-time staff on these islands.
Yeah. So part of the plan, aside from the infrastructure of teledentistry, is hiring the hygienist to be located in Tinian and Rota, so that the doctor remain in Saipan and the dental hygienist perform the basic procedures that can be done assisted through teledentistry. So we are in the process of onboarding those hygienists to be stationed in the islands to perform those basic procedures. And
Okay.
still, yeah.
Thank you. Another question I had was, what would you say are the top 3 health-related matters that is eating a lot of these off-island referral?
For oncology does still cost a lot of money, especially for the radiation, because we don't do radiation on Saipan. We do have a lot of cardiac cases that we have to send. And there's also so a lot of cardiac patients and neuro services, neurosurgery.
And in oncology, do you have like a tier as to what would be the top cancer-related services? Or
I can say that in regards to oral cancer, that is growing. We're seeing a lot in Los Angeles right now, so that's where they're being sent.
okay, so what is the hospital trying to do to address that concern,
We are still
or
doing
through your programs?
Well, we do have our NCD program. We did have an NCD summit, and hoping that some of the lawmakers will be in attendance on that. We didn't get a lot of attendees there, but there's a lot of changes that we believe that require policy changes. In regards to, we even recently we just had the walkability summit, which actually the Speaker of the House attended. And there's a lot of things that we could do collaboratively, together. It's not just promotion of telling people. We can't tell people to change their behavior if it's easier to do the others, it's easier, it's cheaper to buy a can of Spam than buying something, more healthier for them. So there's a lot of things that we need to do in regards to just not just promotion and providing outreach. We're trying to increase access to care. Going back to the primary care, where even for our indigent or sliding fee program, we're actually allowing our doctors, because we're paying for them already, but we're opening access to primary care even if they're uninsured. So but there's some tests that will require that the patients have to pay. So it is, we can offer more programs, we can offer more services if, again, if our costs are somehow, if those things can be the gaps can be reduced.
Thank you. And I know during our previous discussions, we've always, I mean, I've several times I brought up the legislations that we've attempted to do through the past budget, or we tried to apply in the current fiscal year's budget, which is the tobacco tax and the sin tax. And so have you come up with that figure as to what that would look like in terms of revenue, so that could help support the HNP? Were you familiar with the exact mechanism to assess the increase in taxes for tobacco, for example?
Yes, and we did come up with figures. I don't have them right here, but yes, we did come up with numbers for both the sugary drink tax proposals and the tobacco tax increase proposals that we could share with you, and to show you what could be generated in terms of revenue to support HNP, if that's what you're looking at.
So would you say that if we were to, say, agree to the increase in both the tobacco tax and the sugar sweetened beverage tax, would the increases, just the increased amount, be enough to support the entire HNP program?
I wish I had those numbers. I'd have to look through my Excel sheets to come up with that calculation, but off the top of my head, just the increase alone, probably not. As it's been standing, the tobacco control tax and the tobacco settlement monies have not been going to, at least not to CHCC. I don't know if they're going to other health, if they're going to Medicaid, or I don't know. But by and large, very little of that money has been actually going to CHCC. So, and even the tobacco control tax is not the complete tobacco tax, right? It's like 1% of 1% is the tobacco control fund, right? So if we were to look at all of the tobacco taxes, then I would say yes. But we can put together those numbers for you based on the data that we have, and then that could be verified by customs as just a double check.
Okay, thank you. If that's something that you can prepare and provide the committee, that's something that we can look at. Another issue that was brought up was I don't know, I guess for some reason now the patients don't pay up front at the hospital whenever services are being provided, in this sense where, like, I don't know, I guess there's an issue with deductibles and not being fully, or paying the deductible before receiving the percentage. Have you guys been billing Aetna regularly and consistently?
We don't have the patients can go in any other clinic, and when they present themselves in the counter and they are asked if they have met their deductible, it's their attestation that they have met their deductible and not be charged for that visit, right? So because we cannot, the information in the system where we access the Aetna or other portals may not be timely at that point. So we do ask patients that have you met your deductible? And it seems it's easy to say yes, even though it's not. And of course we don't want to burden especially if it's an ER visit or any other emergency visit, right? We cannot deal with collection at that time. So once that visit is settled and billed to the sorry, and
We we do bill, and we do try to collect. In fact, a lot of times we've asked for upfront payment, and a lot of times patients would cancel, would not even go. There is, we're still perceived by a lot of the patients that they can come to the hospital for free. Even our sliding fee program, for example, working closely with the physicians to make sure that they understand also that we have an obligation to collect. It's something that is a challenge because people perceive CHCC as a government entity that is supposed to be supported by the government. So a lot of times they don't necessarily pay upfront. So,
But
but we do try to collect. Our staff try, and I've asked them so many times about it, and they tell me the same thing. We tell them to pay. The answer is always, well, then I'm not going to go to my appointment, or I'm not going to do this, and or they do pay. We have a lot of people that do pay too.
so how do we? Why is it that some providers can determine whether a deductible has been met but not CHCC in real time?
Um, it could be that, for example, in the emergency room, that's something that's not
Right,
available for us.
I understand.
But in the clinics, they could do it. They actually could. It's just that with our health system, I don't know. But we should be able to do that.
And I think it should. I mean, if that that's something to continue to look at. Whether, I mean, maybe offer patients the option of paying into a deductible, whether it be a deposit, so that they can,
Well, a lot of
when it
times,
comes time where like they go to another provider, it's like I have to pay you 500 before I, you know what I mean?
well, and that's the thing, right? Is that the reason why patients come to CHCC is because the other providers will not accept them, right? So they come to CHCC because they could tell them, I don't want to see the doctor if I have to pay. And our doctors, at the end of the day, we're also looking at primary care. We don't want them to come back into the hospital in the ER or to the inpatient. It's cheaper for us to see the patient even in the primary care than seeing the patient in the emergency room or even treating them at the hospital. So of course, there are times when patients would say, I can't pay, but at the end of the day, we'll just let them in because we can't also, we feel like it's more beneficiary for us, cost effective for us to treat them now versus sending them over to the ER or the hospital.
Okay. But okay, so in order to kind of address that, whatever happened to the back then where government employees were allowed to do an allotment to CHCC? Is that something that it still can be done? Okay. Do we have a lot of government employees that are under that allotment program?
Not
Isn't
a
it
lot.
something that the hospital can and should encourage, so that way, it can kind of act like a reserve fund that could be used to address some issues while.
Well, we tell them that they could pay an allotment. They could also do payment agreement. We have a lot of financial assistance to help them out. They're yeah.
Okay.
So we do.
Thank you. Well, I mean, you can go a step further and be, have just like the insurance season, right? A time period where we can get employees to kind of get into that program, so that it becomes less harder on them to see to come in, and so I'm gonna sorry members, I'm gonna kind of wrap this up by shifting gears. Can we get the status of your receivables from fiscal year 21 at 6.8, and your receivables in 2022 at 6.7? What's the status of your receivables from those fiscal years?
So it's another complicated explanation. Whatever is not paid by the insurance would transfer into the patient responsibility portion, and for that we haven't done an actual adjustment because we are prioritizing billing insurance versus reclassifying AR from the insurance to the patient. So as and that's one explanation. And the second one is we're also working with the with GOM payers on doing a reconciliation and settlement of those receivable. A significant portion of those balances are because of the difference between their portal timely billing and what the contract timely billing says. So several bills are like rejected automatically by their portal, which shouldn't be. So that results to manual reconciliation. So a significant portion of that are undergoing reconciliation now with our revenue cycle and the third party payers.
Okay. So you don't have any figures as to how much has already been reconciled and cleared off your book. Okay. And just the last one I have right now. Kate mentioned universal healthcare. Do you have do you have several proposals that you've kind of looked into and to see what would work for the CNMI and what can or which jurisdiction we can mirror off of that has probably looked into this as well?
It's hard to model because we're so unique and we do have a lot of freedoms. I think, coming up with a solution that is tailored to CNMI would be the best. We do have several models that we need to look into, but adding numbers to those models takes investment in actuaries and looking at claims data across different payers, so including Medicaid. So we have a report that we did for the last legislature but we just did that in-house. We didn't have any budget for that. So it's just looking at what kind of universal health insurance models could we explore. And some of those include a Medicaid buy-in program. So piggybacking off of the Medicaid program to be an insurer where, premiums are collected. Another option is to contract universal, government health insurance option out. So expanding essentially the government health insurance plan, through an RFP. And then we do list a status quo option, which is obviously not ideal. But so we can resend that report to you. But the fact is we need to assign numbers, and to assign numbers, we really need to have an investment of, actuarial services and looking at, collecting that necessary data to look at what needs to be collected in order to make that program float.
Okay.
So that's where we're at on that.
Do you have an estimate as to how much how much funding that would need for an actuarial service, or basically just to perform some kind of feasibility study, whether
Palau invested about $1 million in their program. I think it was about $1 million. And that is what the CNMI, the 22nd legislature, sorry, are we in 2022 or 23? Yeah, the 22nd legislature proposed to invest, but then the funding was zeroed out. And that was based on Palau's expense on their program.
Did Palau come up with the report on their study?
I don't have
you know?
access to it. As far as I know, their program is working pretty well.
So they have begun a
Mhm.
universal health
Mhm.
insurance.
Yes, they do.
Okay. Thank you. Any members? Our floor is now open to any other members. All right. I guess I recognize Senator Paul.
Yes. On the utility, based on your budget request here, how are you going to be able to pay the agreement with CUC? Would that be taken care of? Is that addressed?
On our budget request, we incorporated the commercial rate,
I'm sorry?
the commercial rate instead of, so we're hoping that will be the case. And then
With
it's
the
just-
arrears.
With the arrears.
So you're budgeting for the fiscal year 24 plus arrears.
Actually, no, we're just budgeting for the cost of commercial rate.
Okay. So we're hoping that they'll grant you the commercial rate, no? Then CUC will come back to us. Okay. Anyways, I'm looking at your your budget request, and of all the budget expenditure classification, I'm looking at the hemodialysis. Your budget request is for almost 3 million, 2.997. Can I ask, out of this 3 million that you're requesting, this eventually gets paid back to CHCC, right? Not a penny is incurred by CHCC, right?
Only being paid by Medicare and Medicaid. Most of the patients, if not all,
All of them, right?
are Medicare and Medicaid. So again, we're only getting paid by cost. Yeah. And at a percentage.
Yeah, but at the end of the day, actually, you don't really incur a penny expense, right?
We do because there's some that are not Medicare and Medicaid. There are some patients that have actually uninsured or have not contributed to Medicare.
How many do we have? Less than
About 15.
really 15 that are not qualified.
Yeah.
And how do we subsidize them?
That's the problem. We're still
They're
treating
probably non-US, right?
no, some are U.S.
Because I thought if you're US, you're almost.
If you're not contributing, it's a contribution to Medicare. So if you have not contributed to Medicare, you will not be eligible for Medicare.
I mean, to have work at least for a year or something like
It's
that.
a contribution, the contribution to Medicare. Not everybody does, I guess.
These are people that need dialysis but never work in their life, so they never contributed a penny to Medicare, so they're not qualified. That's the first time I hear that. But for the most part, this is paid off. I mean, pretty much, this is not a major budget issue, right? Concern.
Part of the revenue projection. So a portion of the 7 million pertains to dialysis, the local match for the dialysis patients as well. So I don't have the exact breakdown into what services those are, right? Because it's a total cost report, right? They capture all total cost and then they allocate it to Medicaid patients over total population served, right? So a portion of that local match is for the services for hemodialysis.
And just to add on in the policy arena, because that's where you guys are concerned, is the outside of Medicare and Medicaid, private payers largely do not cover dialysis services. So that's a huge issue for us, and that is a regulatory issue that we do not have the power to change, but could be changed in policy.
And usually the patients that are uninsured by Medicare, Medicaid come to CHCC.
Can I ask from Rhoda how many are not covered by Medicaid?
Get the numbers for you.
Yeah, I'm just I'm looking at even the states, Guam, the U.S. They have a lot of these the hemodialysis treatment center. I think that it becomes part of the community already, and I'm just wondering if this is not a major expense. This is something that I'm going to ask you to look at, maybe trying to look at the feasibility of having one on Rhoda. I don't know if there's critical need on Tinian, but that's why I'm asking how many from Rhoda are not covered, because if they're other than capital improvement, I think almost everything else here is covered: professional service, medical general supplies, repairs and maintenance. These are all, I think, could be covered under the Medicare, Medicaid, right? And so I don't know what additional expense would we have if we were to open one on Rhoda. And that's something that I'm not going to spend additional minute discussing this, but I hope that, considering that the federal assistance is there and we have patients from Rhoda that are being moved here, could that be something worthwhile to consider? And because we have the facility on Rhoda, we just have to upgrade it. You're aware, CEO, it's been built for more than 15 years. and still empty, right? So we have CIP money that we can infuse for capital improvement. And so if the typical expenses reflected here can be covered, I don't see why that cannot be possible. So I just want to point that out. Thank you.
All right, noted.
I recognize Vice Chair.
Thank you, Chair. Okay, so can we go back to the utilities? So the budget request for utilities is based on the hope that you would get the commercial rate. Now, have you gotten any indication from anyone, CUC, that that is very likely to happen? Right. And the reason why I'm asking, right, because we want to be realistic about the budget request that you are submitting. And when what we don't want to do is make the assumption that you're going to get the commercial rate and request for that amount. And then when that doesn't happen, what, there's going to be an impact on your CHCC's ability again to deal with CUC's whole, and we're gonna go back to square one where we were just a few months ago. So I don't know if that's a very, I don't know what's the word that I want to use to describe that, but I would have preferred that you guys request what you're actually paying right now, just because the whole idea of converting CHCC to a commercial rate is kind of up in the air right now, and I wouldn't, me personally, I wouldn't have projected, using that assumption. So
Yeah. So
I just don't want us to go back to where we were a few months ago. Where
I understand, and I think it's really important for this body to think of this as a holistic approach. You know, CHCC is not getting paid for a cost
Right.
from Medicaid. We've emphasized that over and over each year when we have a budget discussion about the need to fund it.
Mhm.
And it is why we have a shortfall in paying CUC, paying other things that we are required. And when we look at the government relationship, that's when we say, well, the government doesn't give us this, this is why we're in this situation. We would love to, yeah, of course, we would put that there, put the actual rate that we're paying now, hoping the PCUC will be able to make the adjustment as what we're hoping for. But again, we're also being unrealistic probably by by putting the cost of matching Medicaid, which we're probably not going to get anyway. So, but it needs to be on record that if you want us to pay, to make it reasonable for the health of this community, just look at the significant impact of not paying Medicaid match. Look at the significant impact of what is affecting other agencies like CUC.
Yeah.
Take a look at that. We're asking for all of you to take a look at it and see what it is. When someone comes and criticizes CHEC for not having this and having that, but yet they have in their control to be able to fund the hospital. I am just, surprised that can be, that is not visible to you all. I'm really asking for you all to think about that. I understand, yes, we could take it and put down the actual cost of, and we've done this over and over, where we know that we can ask, we never get what we ask for, but we will continue to do what we can, and we continue to look at what is feasible. We have to look at what is tangible. We have to look at Medicare compliance. That is, as mentioned, Medicare and Medicaid is our biggest payer,
Mhm.
and we need to comply with the requirements as a standard of care. And by the way, we're meeting the standard of care based on Medicare, surveys. So it isn't. Yeah, I agree with you. We could put that there, but again, it is not the real picture of what we're asking you all as policymakers and as appropriators to be able to assist us and say, okay, they need to pay the commercial, the government rate. But what about us? What about the patients that are coming in again? And I've mentioned that even in the hearing with the CUC, we're dealing with a lot of patients coming to us, a business office coming to us asking, we have to pay $20,000 for one patient only for one cycle, and 6 cycles. They need 6 cycles, but this patient is cancer, stage 2, and if we don't treat it, would become stage 3 and stage 4. Why wouldn't we help? So we figure out a way to help. So a lot of our budget, if you look at it, yes, there's heavy in administration, but there's also decisions that need to be made in, and making sure that we look for patient assistance program. We are very fortunate to actually, the reason why I was late earlier was because I was having a direct conversation with an entity that can transport our oncology medications for us, for those companies that can't ship the items to us because of refrigeration. So, it's a conversation that I need to have to make sure these patients have programs that they can assist. So we talked about previous years of previous discussions about, how can we get free housing? We are looking at that, right? I mentioned that to you and also
Yes.
Senator, about that, about, making sure that we have these access. So we're looking at all those things and we'll figure out a way to do it. But honestly, I feel like, we can put that there. We can put the commercial versus government rate. The end of the day is look at also the big picture of what CHCC is contributing to this community without the cost being reimbursed to us. So that's all I asked. I'm sorry, I'm not
No,
trying.
no, no.
I'm not-
I totally sympathize, and I completely understand everything that you have just said. I'm just in anticipation. I'm trying to be as realistic as possible with the figures that you're providing. So because I do know that everything that you're asking for, you're not going to get, which is why I'm asking you to put the actual rate that you are paying now, because you're not going to get what you're asking. But at least if we were reflecting what you're paying right now and we reduce that, it would somehow be maybe closer to what a commercial rate would be. But if we don't know what your actual cost is right now, then we're making the assumption that this is what your cost is, and then that might get reduced. So I'm just trying to anticipate that and making sure that we are reflecting actuals so that we have a better idea and gauge where you guys are, and have that conscious decision to make, when the time comes. So I'm just throwing that out there,
Thank you.
that in order to make critical decisions like that, we have to know what the real picture is.
Correct. Can I just have
Sure.
So the CFO did ask me, what she's going to put there, and I told her to put the commercial rate, only because we want to again emphasize the plea for us to change to that.
Okay.
Currently, right now, we're paying CUC 525,000 per month. Believe me, it is tough to say no to patients for their medical care because we have to pay CUC.
Right.
So that's where we're at now. That's how difficult it is. Thank you.
Okay. Thank you for that clarification. And just one more, Chair, if you don't mind. So I think there's an email dated July 7 from the CFO to you, Esther Munya, and I'm referring to the local match for CPE for 7.1, and this has to do with the. I guess you're requesting to be authorized to offset Chapter 2 and Chapter 7 taxes projected, um, and it says it's included in your projected revenues. So, and I'm looking at the revenue projection worksheet, and where is it on this worksheet that we could find the $7.1 million? Under which down towards the bottom.
Oh, okay. Got it. Projected Medicaid local match. Okay. So I guess I just wanted to raise or maybe check with our legal counsel whether or not there are any legal issues or concerns with regards to offsetting Chapter 2 and Chapter 7 because it involves local and federal laws. Counsel? Okay. Have you checked with your legal counsel perhaps to see if that's authorized or?
We're actually speaking to finance, and we would like to put that in executive session if we were asked to discuss it in executive session.
Okay. Did you want to hear it further? Short recess. Requesting for short recess?
Short recess.
Okay.
In a recess, I think there were several questions, or the vice chair had asked questions in regards to chapter 2 and 7 and some kind of discussions. But I guess if CEO, if you can answer without, disclosing any confidential information, but I guess just to clarify whether future payments on chapter 2 and 7 taxes can be offset with the 7.2 that
I would turn it over to her to get into the details of of the account, but this is executive session, right?
no. I just said whatever you
Okay,
can
okay.
disclose without.
Okay, got it.
Yeah.
Yeah. So it's a discussion that the Secretary of Finance and their legal counsel and our legal counsel are working on. That's all I can disclose. Thank you.
Thank you. Vice Chair, you still have the floor. You, Vice Chair.
Yeah, sorry, I yield.
Thank you. I recognize Senator King Neighbors.
Thank you, Mr. Chairman. I just wanted to know what the final total is that you're requesting for. I know a lot of numbers have been thrown around and segmented off, so just so we don't lose our way.
Sorry, just one moment. We are asking for 9 million. I know that there's 9 million that we're asking for H&P, and hopefully also, and the subsidy. Go ahead.
So our ask is 9.6 million for the H&P program, 1.5 million for subsidy for operation, 4.5 million for capital expenditure, and for the government to fund the local match of 7.1 million. The total ask for CHCC then is 13 million, and for H&P 9.6 million.
Thank you for that. Yeah, I about.
Thank you. One last question to any of the members. All right. If there's none, Vice Chair.
Sorry, Charlie, can we just go back? So you're asking 4.5 for CapEx, and normally CapEx are funded federal grants?
It's a combination of sometimes the central government have capital expenditure funding that goes to us, and then that's why we asked for we broke it down into components of what the asks are. So essentially, for hospital subsidies, just 1.4. The capital expenditure is 4.5, but we could yield that because we could ask congressional appropriation and other funding sources.
Got it.
Yes.
Okay, just wanted to clarify that.
Yes.
Okay, thank you. I yield.
Okay, thank you. Since the Vice Chair brought up that question, why was capital expenditures adjusted out of your budget, the 4.5 million?
To clarify, we are still asking for our budget expenditure to be capped at 121 million. That's including all the vacant position and capex. But for our ask, we are asking only for a subsidy of 1.5 for CHCC. the capex is included in the budget but are pulled out from the request for funding because it could be funded somewhere else.
Okay. So this would be an additional 4.5.
It's included in the the cap that we're asking for. The 121 million as expenditure for the year includes that.
Okay.
But
Thank you.
in calculating the subsidy, we pulled out those number to come up with the requested subsidy of 1.5.
Okay. Understood. Thank you. Clarified. All right, and that concludes the testimony portion of the agenda. If there's anything, CEOs or anything you'd like to provide in closing?
Yeah, I just want to thank you all for the opportunity. I know that not all agencies were asked to come today to present, so we appreciate your engagement in trying to address the situation of HNP as well as the hospital operations. On behalf of the chair, I do. Polly Mosca had to step out, but she does also send her appreciation for having us here, and we're looking forward to the confirmation of the 3 appointees so that we can have a fully functioning a board also. So because there's a lot of things that need to be addressed. I appreciate you. Thank you.
Thank you, CEO Munya, Ms. Caitlin, and Ms. Pearly, and to the rest of your team for coming in today. You are hereby excused. And at this time, we move on to the next item on the agenda, announcements. As a reminder, members, we have Office of Grants Management tomorrow, and then Department of Finance on Friday. Additionally, we will be hearing from our entire budget schedule will consist of the rest of the agencies this week, as well as MVA, DPW, Rhoda and Tinian. And so all other agencies in which we will not be hearing, they can be found in the YouTube channel under the House hearings. And so if any of the members of the public have any concerns, we can refer to those recordings that is available to the public. At this time, members, any other announcement? I recognize Senator Selena Vavta.
Just for the benefit of CHCC, the EAGI committee has called for a meeting to hear and vet the appointments of the 3 nominees for the CHCC board on Thursday, July 20th, 2023, for everyone's information.
Thank
I
you.
yield.
Thank you, Senator Babalta. Any other members? All right, if there's none, can I get a motion for adjournment? All right, motion was made and seconded. All in favor, say aye. All opposed, say nay. Meeting is hereby adjourned at 11:30 p.m.